welcome to the ITP Support Association Scotland Zoom meeting. It's a pleasure to welcome Dr. Catherine Baggott, experts, to this meeting today, and thank you for everyone for joining us. Also want to welcome the ITP Support Association board member, Mr. Anthony Hurd. Anthony is an ITP patient himself and will be, I'm sure, giving you the benefit of some of his experience. So we shall kick on. Just be aware that the meeting is being recorded, as lots of people want to actually look back at the meetings as well and just update themselves on what was said, what questions were said. So thank you very much. Enjoy the meeting, and I will start now. Thank you. Someone must have a question. Mr. Van. Mrs. Van. Go ahead.
Yeah. How long does rituximab last before the platelets drop again?
So that really varies from person to person. So there's actually some good data out there that shows probably about 70–75% of patients will respond to rituximab, but 5 years after receiving the rituximab, only 20% of people remain in remission. So for a lot of people, rituximab is very good, but they will need it again. But how long it lasts for varies hugely from patient to patient. Generally, I feel that if a patient only has a remission for sort of 6 months or less, that's not very good. But once they get to 1, 2, 3 years, that's absolutely great. Some people never need another dose. Obviously, there's 1 in 5 who 1 shot of rituximab and, well, a course of rituximab, and they're sorted. So I'm afraid there isn't a perfect answer to your question. It's somewhere between, not responding at all, but if you respond anytime between 6 months and 5 years. In my experience, if you have a response, it seems to last 1 to 2 years, if not longer. But I have had a couple of patients where it's just been a few months. But we can use it again. I mean, you can use it again.
Because that problem, because my daughter's got ITP and she's a kidney transplant patient as well. And she's a special needs lady, other complications as well. And her rituximab lasts like sometimes 7 months. Sometimes 8 months, but then it all goes down after 9 months.
Yeah, I know. I had it in 2010 and 2013, and I responded very quickly to it. I think I responded within about 2 weeks. It lasted about 3 years on both times, and we opted not to go for it a third time. I'm now on mycophenolate mofetil, so I've been on that since 2016, I think. Yeah, 2016. So yeah, my experience of it was okay. I mean, I didn't have any adverse reaction to it. I think I had shortness of breath after about an hour of the infusion, the first infusion, and they slowed it down very, very dramatically. And I was fine after that. But it's very, very tiring. My experience of it is extremely tiring. It's a very, very long day when you're having one of those infusions, for sure. I think the first one took about 8 hours for me. But anyway, if you want to ask me anything else or about rituximab that I can tell you about, then please, do. I'll leave my email address there if you want, and see what if there's anything else you can think of.
Yeah. Okay. Thanks.
Okay.
Thank you, Mrs. Baird. Any other questions? There must be some. Libby's going to ask one.
I got one more.
You got one more, Mrs. Baird. Hold on.
Yeah.
Libby, was you going to ask a question? You're on mute. We go to Mrs. Baird, and when you find the unmute button, we go, Mrs. Baird.
I just want to know, during this weather with the hay fever going up, and my daughter gets really bad hay fever, does it affect the platelet levels?
Well, the thing is, the ITP is just such an unknown. There are various triggers for it, and they really vary from person to person. I think anything that stimulates any sort of immune reaction can have a beneficial or a bad effect on ITP, but it really varies from person to person. So if you say to me that your daughter gets hay fever and then she finds her platelets go down, that wouldn't surprise me in the slightest. It wouldn't surprise me in the slightest. Just because you're having an immune reaction, you're having an immune reaction, allergic reaction to something, and the immune system will be kicking in to respond to that allergy. And that might have a good effect on the platelets, or it might have a bad effect. So yeah, ITP is a really, really tricky one, and I am never surprised by what anyone tells me, and I think it would be quite reasonable for hay fever to affect ITP.
I think it's one of these where it's hard to rule anything in and it's hard to rule it definitely out. I mean, I concluded after 17 years of this that the only definite thing about ITP is that nothing is definite. That's the problem. You just can't pin anything down for certain. A lot of people talk about what food should we eat, what food should we avoid, what can we do to amend. You really just don't know. It's impossible to say, really. We get lots of questions about that, don't we, Mervyn?
We get loads of questions about that. Yeah, loads. And there's no scientific evidence for any food.
No, I think the thing about food is that, first of all, I'd always say to any patient, just eat normally. Don't no faddish diets, nothing like that. But it's not impossible that there could be foods that stimulate a little bit of reaction in you, whatever that might be. I mean, as an extreme example, if you have lactose intolerance or that could easily stimulate your ITP in one or other direction. But otherwise, I would always say to patients, just eat normally.
Doctor, could you comment for the wider audience about, I mean, I get a lot of queries on social media about alternative treatments, herbal remedies, and all sorts of concoctions. Papaya leaf extract comes up a lot. I don't know if you could care to sort of perhaps warn people about such things.
I mean, the thing is about any, call it natural, whatever alternative, is that we don't have the data. So there's two things I always find a little bit tricky about alternative medicines. I don't mind any alternative treatment that makes people feel better, because having any long-term medical condition can cause stress, can prevent you from sleeping, whatever it might be. So alternatives in that regard, I don't really have a problem with. But two things about saying something will treat ITP is, one is, well, I'd like to know what the mechanism is. Why do we think, say, papaya leaf? What is it about papaya leaf that will have an effect on ITP? Does it have some anti-inflammatory property or some immunosuppressant ability or bone marrow stimulating property? And then the second thing is, I want to see the evidence. So if someone, what we always say is that it's the randomized controlled trial. So you'd want to papaya leaf extract against, I don't know, oak leaf extract to say that, one is better than the other. So, I mean,
the other
those
thing
are my reservations. I think doctors always have a terrible reputation for alternative remedies. But my logic behind it is you need to have some evidence. And in fact, in ITP, it's only been the last sort of 10 to 12 years that we've actually had evidence. We've had very little evidence up until we had these, what we call the TPO mimetics, the L-trombopag and avatrombopag of this world. And then, the clinical trial with rituximab, but not many studies at all. So ITP doesn't have great evidence. But I suppose the difference there is that we know that steroids immunosuppress. We know rituximab immunosuppress. There's a mechanism for why it should work. So we've got a lot of observational data, and the study I was quoting there about rituximab, that is observational data. How long does rituximab last for? And so we now have that data.
In addition, I think I always mention when I reply to such queries that they're unregulated, these things as well. So that's another factor. We don't have the data, as you say. And also, how much of this stuff should you be taking? I mean, should you be taking a spoonful every day or a jugful every day? Who knows? So, there's so many unknowns.
And then the other thing you always have to be careful with is, can they cause any harm?
Absolutely.
Now, I'm not saying papaya leaf extract causes any harm at all. I've got absolutely no idea, but you just don't know. So I think you do have to be very, very careful.
Absolutely.
Okay, Libby, you want your question now?
Yes. Hope I'm not oversharing.
No.
I had my annual phone call yesterday with the consultant and had sent bloods in the day before. the platelets are fine, but he said he'd seen something in the blood cell levels that were connected with iron, and he thought he would send me for what I called camera scopes north and south, and I just wondered if that was I don't know what the readings were, because it takes about 10 days for things to come back into the GP surgery these days. I just wondered what you might see, and if you would. He asked me if I was bleeding anywhere, so I said I wasn't. But I wondered if I could be bleeding somewhere, what I might feel if it wasn't showing out of the normal orifices.
Sure. So, I know exactly what we're talking about.
Yeah.
It's not a problem. So what the doctor's probably seen. So I suspect that your doctor just does a full blood count, mainly
because a consultant. Yes. Yeah.
So he wants to see the full blood count and to look at your platelets. But obviously he gets the whole lot. He gets the hemoglobin and how dark the red cells are, how big the red cells are. He gets all the information. So I suspect if he sort of says there's markers that would indicate that you're low in iron, then your hemoglobin might be a little bit low, or it might just be that you have slightly pale red cells and slightly smaller red cells. And that's a classic finding of what we call iron deficiency or iron deficiency anemia if you've actually got the anemia. And I suspect that your doctor, your consultant, wouldn't automatically do studies to look to see what your iron levels are, but that would be the next step. You can do a simple blood test, look for something called ferritin, and that tells you how good your iron stores are. But when you women who are still having periods, when you see iron deficiency, it's always due to their periods, or it's generally considered due to their periods. If they're postmenopausal, then the next place where you might not know you're bleeding is the bowel. So it is easy to lose blood from the bowel and not know about it. Okay. And there's many causes for that. You know, we know that there's a high rate of polyps in bowels in the Western world, and that's why we now have these bowel screening programs. So that's why these north and south scopes are being considered to see if there's any bleeding. But you can bleed from the bowel and not know you're doing it, and the only way you pick it up is through either finding maybe iron deficiency anemia, or through this bowel screening program, which if you're over the age of 50 in Scotland, you do it every 2 years, and that's a really good way of screening because it looks for blood in the stool. So that's why your consultant is considering, are you going to need to have these north and south cameras?
Just to let you know, Libby, I had last year I had to have 4, let's just say, cameras, colonoscopies, and I did have a perforated bowel, hence the blood, and my iron level was right down. So yeah. You don't notice it at first. Yeah,
he wanted to do that before he said he pumped me with iron or filled me with So but would you? I can understand the one going up through the nose or the mouth, whichever it does. But would a stool sample not be a?
Yeah, well. So there's something. So you've got
a cheaper way, perhaps first.
Yeah,
I mean, you know,
absolutely. So generally, so all doctors vary, but if I met a patient who had absolutely no bowel symptoms, but I found was iron deficient, then the first thing you can do is something more sensitive than the bowel screening. So the bowel screening program that comes through your door is you have to have quite a bit of blood for it to pick it up. But GPs and hospitals can do something much more sensitive called the Q-fit, which can pick up much lower levels of blood in the stool. So, and if you're, as far as I understand, I'm not a gastroenterologist, but as far as I understand, if your Q-fit is negative and you've got no bowel symptoms, the chance of you having anything that's bleeding in your lower bowel is very, very, very small. So I would have thought a Q-fit, this stool sample that's more sensitive that GPs and hospitals can do, is an alternative way to going straight for a colonoscopy, which is not fun.
No, yes, I didn't think quick enough, and I didn't know about the Q-fit. Is that something you can do at home and send in?
No. You yes, sorry. Yes. So you would get the kit from the hospital, or you get the thing, the sort of sample pot from the hospital, and then you'd have to take it back. And you can't sort of send it off in the post, if you like. It has to be handed into GP surgery, and then the test gets sent to the laboratory.
Yeah, in my
everything can be
case,
done.
it was from the GP surgery, and that is how I ended up having several colonoscopies because of the blood. So, yeah, it was the Q-fit as well. Yeah, yeah.
Okay.
Interesting times.
If you want to avoid a colonoscopy, suggest a Q-fit to your consultant hematologist.
Oh, I'll have to phone up and ask, maybe. Yeah.
Yeah,
Okay,
they probably. I
thank
mean,
you.
it's just something to have a discussion about.
Yeah. Okay.
All
Any
right,
other
can I just
questions?
say I'm going to have to leave about 20 minutes early, but anyway,
Okay.
thank you.
Okay.
Thank
Okay.
you.
Hi, Lauren.
Hi, thank you. I was wondering if you could talk about people with A or B blood types potentially receiving IVIG infusions with the risk of having the IgA autoantibody, I think it is.
All right. Okay. So there's a few things just to clarify there. So you've got your blood groups. So you're either A, B, or O. And it doesn't matter what blood group you are, you can get IVIG. But then there's something called IgA deficiency. So that's it, but it's a completely different thing. So we've all got antibodies in our blood and to help us fight infection, and they come in different types: IgG, IgM, and IgA. And there's a very, very small number of people, I think it's by 0.1% or something, who have a really low IgA and have really severe IgA deficiency. And that means that if they're exposed, or it can happen that if they're exposed to something like IVIG, or in fact any blood product, they will see IgA that they've never seen before, and they can have an allergic reaction. Now, the vast majority of people with IgA deficiency actually don't have a reaction to blood, don't have a reaction to IVIG. But if someone, say, has a reaction to IVIG or has a reaction to blood, one of the things we will do is make sure they haven't got IgA deficiency. So obviously these things have all got very similar names. So it's really, so you've got your ABO blood group, IVIG doesn't matter. You've got your very, very rare IgA deficiency, which is an antibody, an immunoglobulin, and you can receive IVIG, but if you had a reaction to it, one of the things they would test for is IgA deficiency.
Is that a simple blood test?
Yes. So it's a very simple blood test. It's just a blood test, and it would measure the levels of IgA, IgM, and IgG, all these different types of immunoglobulins or antibodies, as they can be called.
And if you did have an IgA deficiency, then would that be a contraindication to getting IVIG?
Not necessarily, no. So let's say for some random reason you were having your immunoglobulins checked and you were found to have IgA deficiency, and you'd never had blood before, you never had IVIGs before, you would be able to receive your IVIGs, and you would be monitored just really closely to make sure you didn't have a reaction. And if you had a reaction, it would really depend on the risks and benefits. Let's say you had a reaction. What it is basically an allergic reaction. So you might have facial flushing. You might get a little bit of wheezing in your chest. You might get a rash. And depending on the severity of that reaction and the severity of your ITP, it would then be a balance. Well, how much does this lady need IVIG? Can we use other treatments? So if that happened to one of my patients, I found out they were IgA deficient, they had a reaction to IVIG, I would say, right, we're not going to use IVIG anymore unless we're in a really, really extreme circumstance.
So that allergic reaction wouldn't cause hemolysis. It's more of a...
So if we're talking about IgA deficiency and that allergic reaction, no, that would not cause hemolysis. However, there is something called autoimmune hemolytic anemia, which is like ITP, but against red cells. So in ITP, you've got antibodies against platelets. In autoimmune hemolytic anemia, you've got antibodies against red cells. So having IgA deficiency, well, I was going to say having IgA deficiency doesn't make you at increased risk of these things, but actually it sort of does, because we know that you can have what we call a congenital immunodeficiency, or combined IgA, IgM, IgG deficiencies, and actually that does make you at increased risk of ITP. It's all a little bit complicated, but because one of the things we look for when someone first gets diagnosed with ITP is we look to make sure that they haven't got immunoglobulin deficiencies, because there's something called combined immunodeficiency where you're low in everything that actually puts you at increased risk of ITP. And in fact, that's treated with the IVIG. So it's a bit complicated. Does that sort of answer your question? Had you read something about IgA deficiency?
Yes, and it was also mentioned at the ITP conference in Chicago in July.
It was, yeah.
And
what were they talking? What were they describing at that? What were they mentioning about not using IVIG in patients with IgA deficiency?
They didn't go into detail. They mentioned more the AB blood types potentially having this rare reaction or occurrence, IVIG. I don't remember what the context was. I don't know if you do, Mervyn, or not.
Mervyn, do you remember? I can't think.
It was a very, very brief. They just touched on it very, very briefly. There's no real insight to it. I think it was either Jim Bassell or John Semple mentioned it.
Right.
Yeah, one of them two. When they was on stage.
And it was
it was a very brief.
Right. Yeah, I can't think why blood groups, being blood group A or blood group B or blood group O would have any impact on your response or a reaction to IVIG. But I could have a little look and see if I can work out what was said. Which conference was this set at?
This was the PDSA conference, Platelet Support Association.
Right.
That was held in Chicago back in July, wasn't it? Yeah.
Right.
Yeah.
I can see if I can find out what might have been said, so that next meeting I can try and clarify, or I can send something on to Mervyn, because I certainly don't want to confuse everyone. I'm just sort of trying to pick out what could that have possibly meant. But
what I would say on that is that I think the PDSA are publishing the videos to the talks in Awareness Week. So yeah, just like we're going to be publishing our videos in Awareness Week as well from our conference. So yeah.
It might have been within a conversation that Winrow came up as well, because I think there is some contraindication with Winrow specifically.
Okay. So Winrow, we don't call it that here, but that's anti-D. So that's okay. So basically, that's a slightly different thing, and we don't use anti-D in this country anymore. And this is a very, very interesting concept if you want to hear about it. Basically, if you are so we've talked about blood group A, B, and O, but you're probably all aware you can be A positive or B negative or O negative, and that's all to do with another protein on the outside of your red cells called D. So you're either positive, you've got this D protein on the outside of your red cells, or you're D negative. And they discovered in ITP that if you have someone who is D positive, so they might be O positive or A positive, and you give them anti-D, that let me just get this right. So the D, this anti-D sticks to their red cells, and basically the immune system is so busy getting rid of those red cells now coated with this anti-D that it doesn't have enough time to destroy your platelets. But it does mean that you can be made quite anemic, and you can develop this hemolytic anemia. You're basically inducing a hemolytic anemia by giving people who've got this D protein on the outside of their cells an antibody against that D protein, and the immune system now spends its time gobbling up those red cells so that you don't gobble up your platelets. I always thought it was a bit of a blunt tool, to be honest. And then there were reports, I think, in Europe of people who developed really, really bad hemolytic anemia, and then it was lost its license in the EU to be used for ITP. I hope that makes sense.
Yeah, no, that is really interesting. Yeah.
Good stuff. Any other questions? Thank you, Lauren, for that one. Someone must have a question. Miss Bag?
Yeah, sorry. Yeah, I wanted to ask about this COVID vaccines.
Lord.
Last year,
Oh
No.
no, it's that
Oh,
word
please,
again.
please do, because
It's coming back
very,
as well. Oh
it's
no.
it's a really important point. So I'm really interested to hear what you have to say, because I've got a few things. It's very interesting with ITP.
last time when she had hers, the COVID vaccine, and her platelets were like normal. And then when we went for the blood test after a week, because they asked to get a blood test done, her platelets are really low. And then she got rituximab and everything. And then last time when she had a spring booster, they were just same, nothing happened.
Oh wow! Right, right.
Good.
And now
Good.
we had to have autumn booster. So I'm worried whether to give or not. I have to give her. And she
I
has to
think
have.
this is really, really tricky, and you know, if patients with ITP, we were very, very clear from the UK ITP forum, if you've got ITP, particularly if you're on immunosuppression, you really, really should get all your COVID vaccines without question. We were always really, really clear at that right at the beginning with the vaccine. But we do know without doubt that all vaccines, including COVID, can worsen your ITP. Sometimes temporarily, sometimes for a long time. Sometimes it can worsen your ITP significantly. It's quite rare, but it can happen. And this is why we then came out a bit later and said, right, we actually think that all ITP patients should get a platelet count done a week later, just so that we can see what's happening. And as you say, sometimes people drop their platelets, sometimes they don't, and there's no rhyme or reason to it. It could be due to the batch of the vaccine. It could be due to the fact the vaccine was a little bit different, because we know the vaccine is evolving all the time. The only time now I'm saying that ITP patients should not get a COVID vaccine is if they have had a really, really bad exacerbation of their ITP. And unfortunately, I have had some patients who've had that. But it's rare. When you think about, how many thousands of ITP patients there are in the UK, we're not getting bad ITP relapses that often, but they do happen. And I now probably have about 2 or 3 patients where I've had to say, and they agree, never ever going to have a COVID vaccine again. But it's rare. So I would say, with regard to your daughter, that she should really have her autumn booster. Particularly if she's getting a lot of rituximab. She won't be as good at fighting COVID. I can't guarantee she won't have a reaction, but you've got to, this is the whole thing with really any medical care. You've always got to balance the risks and benefits. So yeah.
I was also going to raise, because it's this time of year where people start thinking about the flu jab and shingles jab, I was going to raise that as a sort of general topic, and wondered what, I presume the advice would be much the same.
Absolutely.
For us vulnerable folk,
yeah. There's no question about that. Yeah.
Should we also then aim to get a platelet count a week after anything like those jabs?
It's difficult, isn't it? I mean, we've sort of, because the world and his wife literally were being vaccinated against COVID. There were, just so many people being vaccinated. We brought out a policy for COVID. But to be honest with you, if you've got ITP and having a flu vaccine, it's probably the same thing, to be honest. We've just never said it, because it's just never been an issue, because there's probably a huge number of ITP patients out there who don't get the flu vaccine. Whereas with the COVID vaccine, there's an enormous number of ITP patients getting the COVID vaccine. And I think that's why it's come to the fore. So
I know certainly from personal experience, shingles was an absolute nightmare. So that's the one I would never want to have that again, for sure.
Because of your ITP.
I had it in 2009, and I was on steroids at the time, and that was absolute hell. It really was the worst thing I've ever had, definitely. So, if anyone is in the vulnerable situation, I would certainly consider the shingles vaccine, if you can get it. But, or at least talk about it with your specialist,
No, I mean, we're all definitely still saying, definitely get vaccinated against COVID infection unless you've had a very, very bad reaction. And even, I mean, obviously this is no fun for a patient, but even if you had to have a short course of steroids to boost your platelet count after having had the vaccine and then it's all gone away, we'd still be saying get the COVID vaccine. It's only people who become really resistant to treatment or have bad bleeding problems that we say don't get the COVID vaccine, and that's very rare.
Is that also the case if your ITP was maybe triggered by the vaccine?
That's a really, really good question.
That's tricky, isn't it?
It really, really is tricky. I could really, this is all about talking to the patient, because a patient may say, there's no way I'm getting the COVID vaccine again. And I would completely respect that, because maybe it wouldn't trigger your ITP again, but I can't guarantee that. And particularly if you've had a really rocky road with your ITP, then fair enough. I mean, if I had a patient who had a vaccine, got ITP, had steroids, recovered very quickly, I'd be saying, well, it's a balance of risks and benefits. Maybe we should give the vaccine again. But it's a conversation between patient and doctor there. There's no wrong answer. But a patient who gets ITP secondary to vaccine, I'm not going to blame them for saying, I don't want the vaccine. We just have to talk about, because obviously we do have treatments for COVID now. There are other options. So vaccine's definitely the best. But if someone's had a bad experience, then it's about balancing the risks and benefits always. Yeah.
Okay, Libby, you got a question?
Well, only I'd missed the bit about during the COVID thing about getting tested a week after. But anyway, if you're not on immunosuppressants, you don't qualify, do you, for the COVID jab now? No,
unless you're over the age of 65. Yeah, that's right.
That's fine.
Okay, and Catherine, in your clinic, have you noticed since COVID any increase in patients presenting with ITP symptoms? Because I know some of your colleagues have.
I don't think so. What I would say is I've noticed more ITP with the vaccination. That I have noticed.
Okay. Interesting.
Yeah. And not so much the early vaccines. It's been the vaccines in 2022 and 2023 that have really seemed to have given us some tricky, difficult cases to treat. But as I say, that is the minority when you think of the literally a few million vaccines being given all the time. It is very, very rare. And it's such a fine balance between saying, okay, be aware of ITP, but also be aware of not getting COVID or the flu or shingles or whatever. And there's no, because we know that, forget COVID for a second, flu kills many thousands of people every year. So whereas if you get ITP, although it's no fun, you're very, very unlikely to die from it. So it I keep saying it, don't I? It's balance of risks and benefits, very much so.
Yeah. Okay. Any other questions? Betty, have you got a question? You're always on these calls, my love.
Quietly listening.
Yeah. You're taking it all in.
Yeah. Yes. Catherine, I'm in remission from ITP. I've never actually been formally told that, but my platelet count is now above the lower end that's regarded as normal. So I just get an annual blood test. I'm in Edinburgh, so I'm with the consultant at the Royal Infirmary. And I've often felt a bit of a fraud, actually, sitting here listening to all these people having all these problems and thinking, oh, is that it? But actually, I was at the conference in May in London, which was fantastic, where I met a lady who Mervyn knows. I can't remember her name, but she told me that she had been in remission for 20 years and then it came back. So I was just wondering whether you had any observations on the likelihood of, well, what does remission mean? Does it mean that your platelet count has gone above the lower end of normal, like mine is?
Yeah. So I think, so we don't know for certain. We know that relapse can happen, many years into the future. Now, I wouldn't want to say as much as 20, but this is one of the things we now know, that in fact, you could have been in remission for 5, 6, 7 years and it can come back. And my experience would be is the longer you go on in remission, the less and less likely it is to come back. But I certainly have had patients who've, been fine for 4 or 5 years and have come back, and then been fine for 3 years and come back. So that definitely is I wouldn't say common, but that is definitely a absolute recognised phenomenon, and I've seen that many times. What I now do with patients who say been in remission for, depends on the patient, but if they've been in remission for 5, 6, 7 years, particularly if they had a trigger. So let's say they got the flu or any viral infection, and then they develop ITP, they get some steroids, and they never have a problem again. That it's all sort of over within like 4 months. And I'll follow them up for a bit. But I do find with those patients, depending on them, I'll say, look, now what ITP is. That you get gum bleeding or bruises or nosebleeds or petechiae, whatever those things might be. We can stop monitoring you. And I have this thing now called patient-initiated review. So I say, you don't have any regular blood tests, because my rationale for this is it's highly unlikely that your ITP is going to relapse on the one day of the year where you get your blood test.
Yeah.
So I say, move you to patient-initiated review. They have the phone number of my secretary. If at any point in the future you start getting nosebleeds, petechiae, you don't have to go through your GP. You just call us, and we'll see you, either immediately because you've got bad bleeding, or within 24 hours or a few days, whatever the symptoms are. Because I sometimes wonder whether I give patients stress by, everything's fine. Oh my God, it's my full blood count of the year, and they're like, oh my God, what's my platelet count going to be? So I've actually moved more towards that, and how soon I do that depends a little bit on the patient. So some patients would find it really difficult to be discharged, whereas others it's an absolute relief. And I shouldn't really call it discharge, because I'm not saying you're completely cured and it's never going to happen again. I'm just saying we've now got to a stage where it's quite unlikely to come back again, and shall we just say, contact me if you develop any symptoms? And a lot of people really like that, because it almost feels they can forget about their ITP. And for the people, I'm just trying to think, I don't think I've actually had anyone relapse who's under patient-initiated review. I've only been doing it during COVID, because that became a really, really common thing during COVID, because we were trying to see patients as little as we could. That if we did have, let's say, a patient with ITP for the last 5 years, or some other very, condition that hadn't needed treatment for ages, we got in contact with them and sort of said, look, you probably don't need to be seen, but we're here if you need us. And that's where this came around. So I haven't had anyone relapse on patient-initiated review, but I certainly have had people who've been absolutely in remission for maybe a couple of years, and then they contact me when it's between appointments, and say, I've got petechiae, and I see them and they've got a platelet count of 5, and we take it from there. So I like to think that patients really get to know their ITP doctor and the ITP team quite well, and I hope they feel confident that they can phone at any time if suddenly symptoms occur between appointments. And that's certainly been the experience of my patients. People who I really thought, oh, you're never going to relapse again. The next thing I know, they've relapsed 2 years since they last had a problem. So I hope that sort of answers your question, but that's what I'm doing.
Yes, no, it's interesting. Yeah.
So I don't
You don't know why. You don't know
Yeah.
why some people go into remission and
No.
It's certainly
we'll learn eventually, but it's
I think with younger children, certainly there is much more evidence that they'll go into remission fairly quickly, isn't there? So we do know that much, and I think generally, again, you use the word generally, the older you get, the more difficult it probably is to see that happen. But then, as we've already highlighted with ITP, there's no certainty. You really can't. You could not say anything for certain.
Yeah, I think children are very, very different. Children often need no treatment, and it is so often has a trigger. So viral infection in particular, vaccines, and then they rarely have significant bleeding. It normally resolves by itself. And in fact, I suspect a lot of paediatricians discharge those children quite quickly. Adults is a little bit different. I think it's something like, 60% of patients relapse. Adult patients relapse. Now it's a very, very loose term that I wouldn't be able to say, well, is that people who, as you drop their prednisolone, they then start to relapse, or is it people who respond to prednisolone, have had a normal platelet count for a year and then relapse? But it's about 60% of patients have some form of relapse. So it's very, very different disease, ITP in adults.
Okay.
One thing that comes up quite a lot.
There's a friend of mine, Anthony.
Sorry,
I'll just interject here.
Yeah, sorry.
There was a friend of mine. He was 6 when he was diagnosed. I only found this out, he's now in his 30s, but he then went into remission within a couple of months, and then it come back again when he was 18.
Wow.
For about 3 years. So you're right, it can just suddenly appear again. Yeah.
And I do know there are definitely children out there. I remember when we were first establishing the UK ITP forum, and some very, very eloquent children spoke. And yeah, I think there was a 13-year-old girl there who was on L-Trombopag. But that is really, really rare that children run into long-term problems.
Okay. Do you think, though, that lots of people with ITP get to know what their body's doing? Because I've had so many ITP patients phone up and say they started feeling fatigue. They know their platelet count's dropped because of the fatigue level. Is that in your experience?
Absolutely.
They know that?
Absolutely. Yeah. So patients, perhaps, I suppose it varies, but perhaps in the early stages. So they're in remission, but we're following them quite closely. They're off all treatment, and they will come in and saying, I am absolutely exhausted. I know my platelet count's going to be down. And they're absolutely right. They've got no bleeding at all. So fatigue is it's such a recognized symptom now of ITP. Yeah, absolutely. I have someone on treatment, and they're only on treatment. They're partly on treatment because they have a very fluctuating platelet count, but they're also on treatment because their fatigue is something that I'd never seen before. And it was a real leap of faith for me. Someone who seemed very sensible, very supportive family, who their world had just fallen apart, couldn't work, couldn't do anything at all. And I thought, is this fatigue of ITP? And I decided to bite the bullet and gave them L-Trombopag. And yes, I can never know whether it was placebo or not, but their life completely turned around. And they have a stable platelet count as well, which is also nice because it was sort of, 207, it was just all over the place. So that's my one very extreme example of fatigue, like they'd never experienced before. And on a cheaper mimetic, it appears to have got better. And we've done things like, and again, you can never know whether this is placebo, but we've reduced the dose, and actually a dose reduction. We did 1 dose reduction and everything was fine. And then we tried another dose reduction and he felt it coming back again. So I've got it's n equals 1. I don't know for certain, but certainly he was a very sensible chap, and I believe him that this made a difference.
Yeah. Well, every survey we've ever done, fatigue is, right up there, like one of the main issues that patients actually shout about. So it's good. Anthony, you had something else?
Yeah, on that subject the fatigue thing, there are a number of very good videos on our YouTube channel about fatigue, which explain why ITP might be linked to fatigue and also how to combat it in some ways. But the only other thing I was going to raise that Doctor was saying, one word that I picked up on, the word was trigger. And we get asked a lot on the social media forums about what could have triggered this, or what could have triggered any autoimmune condition. So I didn't know if there were any. I'm pretty sure I know what the answer is going to be, but
we don't know.
No, that's exactly it. But I mean, one could speculate in all sorts of ways. It could be something. My specialist said, well, it could be something that has happened to you in your life. It could be a life event or even a past life event. If you look at things on a wider scale, because we do store lots of things in here that may not actually transpire till quite a lot later on down the line.
I think the whole time our immune system is getting stimulated. So if you're out in the world eating food, being exposed to the environment, your immune system is constantly registering all these new proteins and things. And your immune system in cells called T cells sort of stores that information. And then, so it could be you get exposed to X when you're 7, and then you get exposed to Y when you're 34, and then when you're 38 you get ITP, because those things have come together. And I think there's so much we we just don't
Just don't
understand.
know.
That's my thought.
Okay.
Good.
Betty, you had a question?
Yes, well, it was to tell you what was happening with me. I've been on L-Trombopag for years, about 9 years or so, and I thought I was fine, everything was going fine, but it started to fluctuate a lot. So the consultant wanted to put me on rombiplostin, and just after I'd taken that, I just had one dose, and my hemoglobin went right down, and I felt dizzy, and I really didn't feel well. And I was at 10, my platelet count was 10. So does this often happen on rombiplostin? Or?
So I don't know so much about the hemoglobin. I can't quite explain that, but we certainly know that you might be on L-Trombopag for a few years. 9 years is quite a long time, but you might be on L-Trombopag for a few years, and suddenly it stops working. Which is really, really frustrating. It's been working all the time, suddenly stops working. One thing we always think about if something like L-Trombopag or rombiplostin stops working, is there any reaction happening in the bone marrow? So I don't know if anyone's experienced this, but when someone loses their response to L-Trombopag or avatrombopag or rombiplostin, we always have a really, really careful look at the blood film. So we look at the blood under the microscope, because sometimes we can get an impression whether there might be some scarring in the bone marrow. Because when you're stimulating the bone marrow for many, many years, there is always this risk of scarring. We've always been very, very aware of this and wanted to make sure we never missed it in someone who was on something like L-Trombopag or rombiplostin. And certainly I have seen people who have developed scarring of their bone marrow. One thing to really reassure everyone about: when you stop the medication, the scarring goes away. So the first thing we think about if someone has fluctuating levels is there a problem in the bone marrow? But then the next thing is, which is most likely to be the case, is that the ITP is just changing character. So, who knows why, but I do have patients who they're on L-Trombopag working perfectly. A few years down the line, the response goes. Then you try rombiplostin and it could work again for another 3 or 4 years, and then the response goes. And there are some patients out there who just, everything's going really, really well, and then suddenly something stops working. And again, we don't know exactly why that happens. So in answer to your question, I don't know why your hemoglobin dropped. The only thing I wonder is, were you having some bleeding if your platelet count was only 10? But I think you also said you felt unwell, didn't you, with it? It was...
I felt dizzy, yeah, but I've been put on avatrombopag now.
Yeah.
And I'm only on a very small dose, and yet it went too high.
Yeah, so that's great. You're sensitive to avatrombopag. So that's, if I have a patient who L-Trombopag doesn't work or stopped working, I'll then go to rombiplostin. Doesn't work or stops working, I'll go to avatrombopag. I'll always try the different ones. It's incredible how you can be resistant to one type of these drugs and have a really good response to the others. Avatrombopag is a really interesting one, actually. We do see incredible sensitivity to avatrombopag, where people, have really been having trouble, give them avatrombopag, and suddenly the platelet count shoots into the sky, which is okay. You just have to, fiddle with the dose until you've got it just right, and it really varies from person to person. So, well, I'm pleased avatrombopag's working. That's great. Long may it last, and at least you can have milk and cheese now at bedtime.
Thank you.
That was one of the plus points of getting avatrombopag agreed, wasn't it?
Absolutely, absolutely. Now I still try and encourage people to try L-Trombopag first. We have to be really careful with the expense. So I do encourage people to try L-Trombopag first, and if that works, then great. But if it doesn't work, then we'll go to avatrombopag. Eventually, all these things will be off patent, and we can just do what we want.
They will eventually. Yes.
We do have to be a little bit careful. Yeah.
Okay. Any other questions? Anyone?
Can I just ask that? Sorry, thank you. Just wondering if there are exceptions, I guess, saying obviously the cost influences trying L-Trombopag first, but if you have a patient who's been refractory to multiple treatments, but not L-Trombopag yet, would there be a case to be made to go straight to avatrombopag?
don't think so. So avatrombopag we don't think is better than avatrombopag we don't think is better than eltrombopag, although there's been no head-to-head comparisons. So it's not that if you're, I mean, these days, certainly me and I think most of my colleagues now, if someone doesn't respond to prednisolone or they start to relapse quite quickly off prednisolone, we go straight to a TPO mimetic. So you're never going to find a highly resistant patient who hasn't been exposed to TPO mimetics, the romiplostins and eltrombopags, very early on, because we all just want to avoid immunosuppression. And and eltrombopag and romiplostim have all been through randomized controlled trials. We know they're effective in 80% plus of patients. It's a no-brainer to not use them, even though they are far more expensive. So I don't think you'd ever end up in the situation you describe, where someone's really resistant. They would have been through all those first.
Okay. Any other questions, everyone?
Well, I've certainly had my brain tweaked this evening, I have to say.
You have, haven't you? You have, yeah. Yeah. Okay. Just a couple of things coming up. As Anthony and myself mentioned earlier, we've got Awareness Week coming up, the last week in September. I am working on a webinar for Awareness Week with our friends in the USA and colleagues in Australia and Italy. So it's going to be some weird event. And, looking at the other monitor, I've had another email about it. I'm getting loads of emails about it. But so that'll be interesting. As I've also said, we've got a paediatric, one of these type meetings coming up on the Wednesday of Awareness Week with John Granger. So if anyone's got any children, etc., with ITP, pass the word out. We can, try and get as many people as possible on that. We've also got another one of these next week with Professor Adrian Newland. So that'll be quite good. And there's also something else I should mention. We've had a scholarship fund going now for about a year, Anthony.
Yeah, just over a year.
Where
I think,
we've had, we've got 3 grants of £250, 1 grant of £750, and 1 grant of £1,500. All people have got to do is write in if they're in further education. It could be any age in further education, because I know lots of older people now are going back into advanced learning. All you have to do is just write in, tell us your ITP story, how the money would help you, and the board are going to assess who to give the money to. Now, we've had it a year and no one's applied.
Oh my goodness!
I can't,
quite surprising,
we just
really.
can't believe it. So
amazing. We can't give
it's
money
there.
away.
It's advertised on our website.
Yeah.
It's also going in the next platelet journal as well. So if anyone knows anyone, please.
Yeah, I suppose I was just thinking when you were mentioning it, people might sort of think, well, what would I use it for? I suppose you're thinking about things like getting to patient meetings and things like that to come maybe accommodation and that sort of thing.
That's it. Or if they are at college, any books or stuff they need, it might even pay for a laptop for someone.
Yeah.
Stuff like that. Myriad of things, but it's there. So we've allocated the money and we still haven't spent it. So yeah.
I mean, and the other thing I suppose is, mention it at things like this, but also mention it at all the meetings that are held. To really get the message out. Yeah.
And finally, we did a survey in the last couple of months for people. Where would they like to see the next ITP Support Association annual patient conference? And London came out way ahead again.
Yeah,
I don't know. So London centric.
Yeah, I agree. I agree.
So what we've done,
what can you do?
We booked the Cavendish Centre in London for next May, and then in 2025 we're having our conference at Bridgewater Hall in Manchester. They're both booked, so the next 2 years are booked. booked ahead. So yeah,
the Cavendish Centre is very good, isn't it?
Cavendish Centre
is a nice venue. That
that's where Nikki Cooper has her update days. Catherine.
Yeah.
And her update day is actually taking place the day before.
Oh, excellent. Yeah.
So in the same venue. So that's quite good. So I'll be advertising tickets for that shortly. And Lauren, are you over here now?
Not quite. I'll be there end of September.
End of September. Okay, give us a call when you're over. Yeah.
Will do.
Yeah, I met Lauren in the States, and you know, she's coming over there here to live, aren't you?
Yeah, I was living in Scotland before, but I'm coming back and I'll be living in England this time.
Yeah. Okay.
Yeah.
Can't resist the place. That's what it is.
Yeah.
Okay, everyone. Thank you very much for joining us. It's been a pleasure. Thank you, Catherine, as always.
Thanks.
Pleasure as always.
Thank you, Sue, Lauren,
Thank you.
Mr. and Mrs. Bad, Betty, Anthony. Thank you.
Thank you.
And by phone
Enjoyed
5.
it. Thanks, everyone.
Bye.
Thanks for your time.
Take care.
Thanks
Thank
a
you.
lot, then.
Bye-bye.
Take